Thank you very much for inviting me. I wish we were all meeting live in Emory, but I don't know if anyone knows there's a virus going around. But this has been phenomenal. And as I'm talking, am I on? Yeah, I think I'm on. As Dr. Johnson said, when Dr. Rosberg calls, you come running. So we're going to talk about intraoperative radiation therapy. Again, I'm privileged to be here. This is a great honor for me. Dr. Rosberg and the group do a phenomenal job, and again, this is a great honor for me to be here. Disclosures: I have some honorarium for speaking with Zeiss, some honorarium for WebEx for Varian, and I am the NRG Oncology Previous Chair for Gynecology. So what is intraoperative radiation? It's radiation at the time of surgery. I don't put too much into this discussion, but this actually has some very, very interesting avenues for patients who have a hard time getting to the physician. So disparity. It also has some very good applications when it comes to COVID. If you could do all the radiation in a single fraction at the time of treatment. There are various techniques for intraoperative radiation. There is an electron beam from a linear accelerator, which is called intraoperative electron radiation therapy. I'll touch on that very briefly just so you have a background. There's high dose rate brachytherapy, low dose brachytherapy. Those are not done very often, so I'm going to kind of skip that in the interest of time. But we will talk about 50 kV photon radiation, which is either the Zeiss Intrabeam or the Zoft, and that's what I've done most of the intraoperative radiation on in my time. This is a trial that was published in 2013 of intraoperative radiotherapy versus external beam radiotherapy. So normally we give radiation after lumpectomy for breast cancer. We also give it after mastectomy for certain indications. But we give radiation after lumpectomy to reduce the risk of the cancer coming back in the breast or in the lymph nodes around the breast in certain circumstances. If it comes back in the breast, it typically comes back right where the surgery was at. So there's a lot of work in treating just that area. And by doing it at the time of surgery, you can get everything done in a single setting. So there's some really interesting quality of life, health disparity, cost, and other avenues that seems this might be an interesting thing to do. So this trial used an electron therapy. I won't bore you too much with the details, but it's 1,305 patients were enrolled. They were randomly assigned between the single dose of intraoperative radiation versus standard daily radiation for about 4 weeks, after 3 to 6 weeks, depending on how the course was given after the surgery. It was a significant trial in the sense there was over 1,300 patients. The median follow-up was almost 6 years at the time this was published. And the 5-year ipsilateral, which means the breast that had the surgery, and recurrence rate was 4.4% in the patients that got the intraoperative radiation and 0.4% in the patients that had the regular outside radiation. And there was no difference in survival. And this is a busy slide. Again, I won't bore you with the details, but overall, everyone did reasonably good. There was a significant difference in the recurrence rates, but the recurrence rates with this intraoperative radiation were still under 5%. And then there was a subgroup analysis of the patients that were the best risk patients to treat, noting a 1.5% local recurrence rate, which is excellent, an excellent option in certain patients. But what I'm going to focus on is Intrabeam. It's the machine that I've been treating on for about 10 years. And who you just heard from, Dr. O'Regan, and I were at Northwestern together for a long time. And we bought this at Northwestern about a decade ago. And then when I moved across town, I brought it with me. It is a mobile radiation therapy platform based on low-energy X-rays. This area here is where the area is where the radiation comes out in this little ball, and we'll talk a little bit about this. Again, this is the target technique. The radiation is delivered from that area in the box and delivered to the ball that gets placed into the area where the lumpectomy is done. I just put this in because I think this looks cool. These are soft X-rays, which means they're very low energy. They've got a small high dose region, so areas outside the lumpectomy bed get very little radiation. They have quick attenuation, and the shielding is very easy, which means you don't need anything special room to do these, and you can do these in a regular OR with relatively limited shielding for radiation protection. There are really 4 different strategies when you're doing intraoperative radiation. The primary one is to do intraoperative radiation at the time of the initial lumpectomy, and I'll talk a little bit of why this might be scientifically an interesting thing to do. There's also secondary IORT, which is done after the primary lumpectomy, where you bring the patient back to the OR. Really not done much, especially in this country anymore, because we think the recurrence rate is higher. In the interest of time, I'm not going to talk about that. Or you can do it in addition to outside radiation as a plan, what's called a boost, which means give a little extra to the area at highest risk, but still treat the whole breast, and an unplanned boost, which I'll talk about. So is there a biological rationale for a single fraction of radiotherapy at the time of surgery, especially with low kilovoltage radiation? I think there is. You know, for those of us that do radiation therapy, when we treat benign diseases like keloid and heterotopic ossification for the hip, we treat within a day because we think that if you wait longer, it doesn't work as well. But yet we let cancer wait 4 weeks usually between surgery and radiation. This is an interesting study where they took 45 patients, 20 treated with this intraoperative technique, and they just collected the fluid from the lumpectomy bed for those 24 hours and then tried to grow breast cancer cells. And the cells that were treated with target did not grow, but the cells that weren't treated with target grew just fine, suggesting that not only might we be killing cancer cells by treating at the time of surgery, we're really changing the milieu and causing a difference in the body that makes cancer cells the ability for cancer cells to grow being abrogated. And this probably has to do a lot with some of the oncological pathways, and this is called the epithelial growth factor pathway. And treating at the time really does not only kill cancer cells, but makes cell-to-cell communication different. And that may be a lot of why it works and why it's so important to treat at the time of surgery. Because in the interest of time, I'm not talking about the patients that came back from surgery, but those patients had a much higher recurrence rate. And this is just the same way of showing it in another form. Is there a physics rationale? So physics is how radiation is delivered. And actually, the soft radiation actually works better than radiation from the outside. It has a bigger biological effect. So for the same dose, you kill a lot more cancer cells. So again, this is kind of a busy physics slide, but it does so that intrabeam, or the Zeiss machine, or soft radiation has a bigger effect on cells than the typical radiation we deliver after breast surgery, which again may be why this seems to work very well. And again, this is just another example how, despite the dose being a little bit lower than what we would expect to give to deliver treatment to cancer cells, it really seems to work just as well for both the things of delivering at the time of surgery and the fact that the soft radiation works better than outside radiation. So I would say there's 2 main 50 kilovoltage machines. There's the Intrabeam Zeiss machine and there's the Zoft machine. They are different. So I don't think we know if the way of delivering with Zoft is as good, better, or worse. There's just not a lot of big randomized studies that we'll talk about. And again, I won't belabor this point, but the physics of the 2 beams are different. So it's unclear if the outcomes would be exactly the same between the two treatments. So first, this was used as a boost, as an extra radiation to the lumpectomy bed, and then the patients then would be delivered outside radiation afterwards. And this was a way to target the lumpectomy and make sure you're treating it. In the era of oncoplastic surgeries, which is where the surgeon kind of makes the breast cosmesis as good as possible, and it kind of changes the way the breast, way the lumpectomy bed is, and makes it a little bit harder to define for a boost. This might actually be even more important. And again, this was done. It seems to be very safe and effective to deliver 20 gray, which is a dose of radiation, to the surface of this applicator, then about 46 gray from the outside. It seemed to have excellent cosmesis, and as long as you waited 4 weeks, the scarring was equivalent. And this is probably one of the bigger reported articles. It was reported in 2011. And the 5-year local recurrence rate, that is how often the cancer came back right around the lumpectomy, was less than 2%, which is half the expected recurrence rate. So in patients who are at high risk for local recurrence after lumpectomy, This may be a way to deliver, especially if an oncoplastic procedure is performed, a way to reduce the recurrence rate and make sure you're treating the actual area at highest risk. This led to a randomized trial, a flip of a coin trial, how we make any real big decisions in cancer care, trying to detect about a 3% difference in recurrence. This trial continues, and we'd be excited to see the results. But what about IORT as the only form of adjuvant radiation? That's exciting. The patient gets surgery. When they wake up, they're done with all their local therapy. I think, again, like I mentioned before, from a disparity standpoint of patients of mine that have a hard time getting back and forth, this is an excellent thing. Compliance, obviously the compliance with the adjuvant therapy is completed. And in addition, in the COVID era, it reduces the amount of time you're in the hospital. So Target A was a very big randomized flip of a coin trial between this intraoperative radiation versus standard external beam radiation. The eligibility was 45 years and older because younger people tend to have a little bit higher risk of recurrence, so it was felt that we would limit this to patients that are a little bit older, although 45 seems very young to me. Unifocal invasive ductal, and then you would give other radiation if there was a surprise, if it was a different type of tumor, if it was a little bit more risk, if there was positive lymph nodes. It was not clearly radiation versus external beam or intraop versus external beam. There was external beam after some of the patients. And then if you had a margin that was positive, you would re-excise and then give external beam. This is just some of the initial complication data. They seem to be very similar in complications. When I first started doing this, was very worried about infection and wound healing, but again, it seems to be very safe. The rates of fluid in the lumpectomy bed are a little bit higher, but still very low. The clinically significant toxicity possibly a little bit higher with the external beam. Overall, though, very low. The wound breakdowns are under 3%. So this seems to be a very safe and very minimally toxic treatment. Cosmesis, a lot of papers on how the breast looks. I personally think the cosmesis is better than external beam, but over 2 to 3 years are about the same. But I do think that in most cases, I actually think that in my own limited experience or my own experience, it's better. This is a study that was just published. So this is an excellent time to be talking about this trial. This was just published this last month, the Target A trial, which is a flip of a coin randomized trial, 2,300 patients. That's a big study in local breast treatment. About 1,140 got IORT, about 1,158 got regular radiation. About 20% of the patients that got IORT then got external beam radiation, with this used as the boost because of higher risk features. And everyone on the external beam obviously got external beam. And cut to the chase for the results. The results were surprisingly good. In the intraoperative arm, again, with some of the patients getting some external beam radiation, the risk of recurrence at 5 years was only 2.11%. With regular radiation, it was just under 1%. So there was a 1.16% difference. With a predefined 2.5 non-inferiority margin, which means it was considered the same if it was in 2.5%. So these are pretty darn good results for a very large trial. And again, this is just in graphic form. What is interesting is that the survival was the same, although slightly improved with the target patients, especially in non-breast cancer deaths. So there was for sure no decrement to survival, and possibly a little improvement with target. It's a little hard to explain at 5 years with breast cancer. But it is the data is the data. So certainly not worse, and possibly a little bit better, especially non-breast cancer deaths. And then this is just a couple things. Cosmesis and pain seem to be improved in the target trial, and some very good follow-up. I'm going to skip this, just showing that this is target retrospective, which just means we published this a few years ago, and there were 1,000 patients we accumulate, just the patients in the U.S. that have gotten target treatments. I think it is more and more becoming a good option for early stage breast cancer. And I'm going to, in the interest of time, just skip this and basically say, in conclusion, breast conservation, that is not doing a mastectomy, is certainly a standard option for early stage breast cancer. And partial breast radiation, that is just treating the area at highest risk, is a reasonable option in an appropriate patient. And target now with extended follow-up and a publication with a good median follow-up really does seem to be a reasonable option in appropriate patients, and I think an option, especially in the COVID era, that should be looked at in most patients that are getting breast conservation. And thank you for your time and attention.